The broadcast is now starting. All attendees are in listen-only mode.
Hi everybody, and welcome to the National Hispanic and Latinos ATTC webinar, Psychosocial Interventions for Hispanics, Evidence-Based and Beyond. Today's webinar will be presented by Dr. Luis Torres. He is Associate Professor in the Graduate College of Social Work at the University of Houston and a Senior Researcher with both the Center for Drug and Social Policy Research and the Child and Family Center for Innovative Research. But I will tell you more about him later. During today's webinar, all participants will be muted. The audio will be streamed through the computer, so please make sure your computer speakers are turned on and off to hear today's presentation. Now I'm going to review a few housekeeping items. If you notice that your viewer does not fit your screen, you can expand it by clicking the Expand button located in the top right corner indicated by the red arrow. Now you'll see that your viewer is expanded to fit the entire screen. Also, you can collapse the GoToWebinar toolbar on the right of your screen by clicking on the small red arrow on the left of the toolbar. Then click the arrow again to expand the toolbar and it will expand. As I mentioned, for today's webinar, all participants will be muted as we move through the presentation. If you have any questions for our presenter, you can just use the chat box on the toolbar. Simply type your question and hit send. We can pause for our presenter to address questions at an appropriate time during today's presentation, and we will do so again at the conclusion. A recording of today's webinar along with the PowerPoint slides will be available at www.attcnetwork.org/Hispanic Latino approximately 1 week from today. You can also find recordings and PowerPoint slides from all of our past webinars at the same URL. I want to mention that for today's webinar, we have one NADAC, one MBCC, and one IC&RC Continuing Education credit available for those who attend today's live event. So if you're interested in obtaining CEUs from this organization, please send us an email at hispaniclatino@uccaribe.edu. Today's webinar is sponsored by the National Hispanic and Latino ATTC. As of October 1st of 2012, the network has been restructured and now consists of 10 regional ATTCs, 4 national focus area ATTCs, along with the network coordinating office. As you can see by this map, the ATTC network regions were realigned to better fit the current HHS regions, and the 4 national focus area ATTCs are listed on the left of the screen. Today's webinar is the 16th in a series that the National Hispanic and Latino has been offering. The network is funded by SAMHSA and serves a critical role in improving the health of the United States. The network achieves this by translating, disseminating, and promoting the adoption and implementation of evidence-based clinical practices and strives to improve the health and wellness of individuals whose lives have been impacted by substance use disorders. As I mentioned, the ATTC network is funded by SAMHSA. SAMHSA strives to reduce the impact of substance use and mental illness on America's communities through its programs and services, and demonstrates that behavioral health is essential to health, that prevention works, treatment is effective, and people recover from mental and substance use disorders. Now I'm going to introduce our presenter. Luis Torres is Associate Professor of the Graduate College of Social Work at the University of Houston and Senior Researcher with both the Center for Drug and Social Policy Research and the Child and Family Center for Innovative Research. His research agenda focuses on health disparities, specifically co-occurring mental health, substance use, and medical disorders in Hispanics, and on family strengthening efforts with a focus on Hispanic communities. Dr. Torres is currently the principal investigator of a 3-year grant from the Substance Abuse and Mental Health Services Administration to conduct screenings and navigation into care with the goal of preventing mental illness, substance use disorders, and HIV/AIDS among Hispanics and African American students ages 18 to 24 at the University of Houston, and among Hispanics and African Americans ages 18 to 24 in the communities surrounding the university. This was the first UH grant to leverage the university status as a Hispanic service institution. Dr. Torres is also co-principal investigator of a NIDA-funded multi-site study examining the effectiveness of recovery high schools in 3 states, and co-PI of the NIDA-funded University of Houston Drug Abuse Research Development Program. Dr. Torres is the PI of the primary research project, Virtual Reality Cue Reactivity, Assessment of Reactivity and Extinction Protocols in Injection and Non-Injection Heroin Use in Mexican Americans, which is examining a virtual reality intervention to extinguish cravings in young Mexican American non-injection heroin users and older Mexican American injection drug users. Dr. Torres served for 3 years on the Administration for Children and Families Hispanic Research Board Group and is currently on the board of the National Alliance for Hispanic Families. As a recognized expert on family and community strengthening efforts with Hispanics, Dr. Torres was co-PI in a 5-year national implementation evaluation of grantees in the Federal Hispanic Healthy Marriage Initiative, focusing on issues of cultural resonance and cultural adaptations, and is currently co-PI in a national study examining programs that serve Hispanic fathers. Dr. Torres is a native of Puerto Rico, has a doctorate in clinical psychology from Fordham University in New York City, and over 25 years of clinical, administrative, and research experience. Okay, so now we're going to learn a little bit more about our audience. And for that, we're going to be doing a poll questioning. And we start with question number 1. Do you currently serve Hispanic and Latino populations with substance use disorders? And 82 of our participants say yes. Our next question is, are you planning to serve Hispanic and Latino populations with substance use disorders in the next 6 months? We have 88% say yes. Our next question, which field of work do you represent? Okay, and we have 44% mental health, 29 substance use, 22 education. What is your current professional role? And we have 40% social work case management, 40% counselor therapy, 6% student faculty. What type of setting do you currently work in? And we have 49% substance use treatment inpatient, 13% university, 11% primary care, and 28% managed care organization. Now we're going to have a pre-test. It includes 3 questions, and the first one is, the term evidence-based practice refers only to manipulated or canned interventions. This is a true-false. And we have 78% false, 21% true. Next one. When considering EBPs, the best research, providers' clinical expertise, and clients' characteristics and culture are essential. And we have 98% true, 2% false. And the last one. There are thousands of evidence-based interventions for Hispanics and Latinos with mental health and substance use disorders. And for that one, 95% say false and 6% say true. Okay, so those are our questions for now. Now I'm going to turn over the screen to Dr. Luis Torres, who will begin the presentation. Remember that if you have any questions, you may use the chat box to ask our questions.
That is my screen up?
Yes, it is.
Okay. Good morning, or good afternoon, depending on where you are. I'm delighted to be participating in this webinar by the National Hispanic and Latino Addiction Technology Transfer Center on psychosocial interventions for Hispanics. Based on the responses to the pre-test question, I can see that it's a savvy audience that already knows something about the topic, so we're going to be able to have a nice discussion, which is what my goal is, to be able to provide some information, but more importantly to generate a dialogue about what are some of the challenges with using an evidence-based approach, particularly to treating conditions that minority communities contend with. So it's always nice to start with acknowledgements, thanking the people that make it possible for us to do the work that we do. So I want to thank the staff at the National Hispanic Latino Addiction Technology Transfer for their support and their collaboration over the years. The National Alliance for Hispanic Families, on which board I sit, which actually commissioned the white paper that some of my presentation is based on today. And then the two current research grants that we have here at the University of Houston that are allowing us to conduct some real cutting-edge research in drug abuse and mental health services. And Darish mentioned a little bit about them. One is from NIDA, and it's an infrastructure development center grant, and we're doing research with injection and non-injection heroin users, particularly Hispanic, Mexican American populations. And the second one is a SAMHSA grant that we're doing screening, mental health, substance abuse, and drug use, and HIV screening with Hispanics and African Americans, young adults 18 to 24, both on campus and in the community surrounding campus. And in both of these, we're using some evidence-based approaches. So my game plan for today, I'm planning to talk about 30 minutes so we can leave enough time for questions. Just a little overview on what is evidence-based practice and why is it important, why is it that we keep hearing about it over and over again. I'm going to talk a little bit about what are some of the challenges, implications for funding and for service delivery within an evidence-based practice model. Then I'll speak specifically about Hispanics. Where are we? What is the state of the evidence on evidence-based practices for Hispanics, and in particular for mental health and substance use disorders, where 73% of the audience comes from, providers of mental health services and providers of substance use services. And then a little bit about where do we go from here, and I end with some recommendations, and then we'll open it up for questions and discussions and comments. So let's start with definitions. What is evidence-based practice? There are three common definitions that we see all the time in different literature, and they have more or less similar elements. The first one is from the Institute of Medicine, and it defines evidence-based practice as the integration of best research evidence and clinical expertise with patient values. The American Psychological Association has a similar definition and speaks of the integration of the best available research with clinical expertise in the context of patient characteristics, culture, and preferences. The National Association of Social Workers has a little bit more expanded definition that has multiple points on it. And NASW calls evidence-based practice a process that involves multiple steps, creating an answerable question, a question that can be answered based on a need of a client or an organization that we're working with, locating the best available evidence to answer that question, evaluating the quality of the evidence as well as how applicable it might be to the client or organization that we're working with, applying the evidence, and then evaluating the effectiveness and efficiency of the solution. And I'll talk a little bit more about all of this as I go through. So all three definitions have these three important components. The central role of empirical support or research. So basically that's what we're talking about when we use the term evidence. So the evidence can come from research, and typically we lean heavily on evidence that comes from research or from the empirical process. I'll talk a little bit more about that in a moment. And all three of the definitions talk about that. Evidence-based as both process and practice is the second one. The first two definitions, the one from the Institute of Medicine and APA, kind of hint at process because they use the word integrate. Integration of various things, and in order to have that integration take place, there needs to be a process whereby it's integrated. The definition from the National Association of Social Workers actually uses the term process and calls it a process, and we're going to again expand on each of these points in a moment. And then the third piece is the importance of attending to patient characteristics, including the culture of the client, the context within which the client's problem is occurring, and the preferences that the client may have. Unfortunately, all too often in a lot of treatment settings, we lean more heavily on the first of those three definitions, the central role of empirically support or research. And looking at what's the evidence behind evidence-based practice is only one of the components that we need to pay attention to. We always need to pay attention to the other two. Let's unpack this a little bit. So why is it that evidence-based practice is important? Well, this isn't new. We've been talking about evidence-based practice now for a long time. Why have recently in the last decade have we seen a marked increase in the or a focus on evidence-based practice? Practitioners have long used current scientific knowledge to support their assessment and intervention choices. So what has changed? Well, what has changed is the ever-increasing focus on evidence. Third-party payers, policymakers, the people who pass policies and laws, and funders, the people who fund, are increasingly expecting, and in some cases demanding, that evidence-based interventions be used as a requirement for payment or for funding. So that's the starter, right? That's the push. The push comes a lot from how do we fund our service environment. But it doesn't stop there. Providers in medicine, human services, social services, they're under increasing pressure to select treatment interventions that are backed by empirical support. And some of this pressure comes from outside, but some of this pressure also comes from within. As ethical providers, we owe it to our clients that whatever it is that we're doing with them works, that there is at least a promise that the client is going to improve. So the pressure isn't just coming from outside, it's coming from within as well. It doesn't matter what we're providing services for, whether it's cancer or depression, enhancing parenting skills or increasing relationship functioning in a couple, preventing drug use or treating drug use, preventing unplanned pregnancies or HIV transmission, increasing self-esteem or high school completion rates, gang prevention, whatever it is that we're providing services for, service providers are under increasing pressure to select and deliver interventions that are based on evidence. And I want to reemphasize what I said a moment ago, that this pressure isn't just coming from funding sources. That's a big a big push, obviously, but it's also coming from within. We are ethical providers, and we want to make sure that we're providing something for our clients that actually works. But there's another place where the pressure is also coming from, and it's from the clients themselves. Whatever we call them, patients, clients, consumers, have also embraced this evidence-based movement, and they expect the best treatment that evidence can provide and that money can buy. The internet has made accessing information as easy as opening up a browser and entering a search term. Even the most sophisticated information, which was previously available only to providers and expensive textbooks or journals or going to conferences, is now available to consumers at the click of a mouse. So it's, when a client goes to see a provider for the first time, chances are that that client has already done some of his or her homework, and they've researched what it is that they're experiencing, their symptoms, and they have a list of questions that they want to ask the provider. It's not uncommon these days for a client to show up at the office and tell the provider, this is the treatment I want because I read online that it's the best treatment for my symptoms. Now, that's not a bad problem to have. It's good to have educated consumers. At the end of the day, clients can't be passive recipients of services. We want them to be actively involved in their treatment, and the more they know about their treatment, the better it is. So some providers that are not used to that kind of push back a little bit, but from my point of view, that's actually a pretty good thing. The challenge is that we may not yet have the best evidence for everything or for all populations. And we'll talk a little bit more about that further down in the presentation. So what is it that we're talking about when we're talking about the evidence? Well, evidence can be seen along a continuum of research, empirical support, and other types of supports. Unfortunately, all too often, the emphasis is on the first bullet, randomized clinical trials, evidence that's arrived at by use of experimental methodologies. And just to brush up on what some of you may have learned in school, the experimental methodology, the experiment is the one where you have, in its most basic form, you have two groups, one that are identical in every way that's possible or that's relevant to the condition that I'm testing. One group gets randomly assigned to an experimental group where they're going to get an intervention. The other group gets assigned to a control group where they're going to get a placebo or a different kind of intervention. And then they're assessed on a variety of measures before the intervention, and then they're assessed again after the intervention. And what we want to see is that the group that received the intervention that we're testing had outcomes that were superior to the other group. So that's the randomized clinical trial or the experimental model. But it's not the only way in which we can gather evidence of an intervention's ability to help a client. There really is no consistent agreement on what a hierarchy of best available evidence looks like. At the other end of the continuum, I was just talking about randomized clinical trials, at the other end of the continuum might be sources of evidence such as personal experience, word of mouth, and community-defined evidence. A person might be helped by an intervention that lacks a large basis of empirical support, and they're going to go out and tell others about it. Word of mouth is often the most important reason why someone decides to try something. And in communities of color, and particularly where word of mouth referrals are especially critical, a demand for the intervention is then created. Often, more formal providers are going to squirm uncomfortably about this rather than saying, well, here might be an opportunity to test this intervention more systematically. And just because the formal establishment may squirm a little bit doesn't mean that the community is going to stop using the intervention that they heard somebody rave about. You go to a Latino community, and if the comadre is saying that this works, everybody's going to try it. The opportunity to gather evidence organically in a situation like that might be lost if we place the emphasis only on funding interventions that already have a higher form of evidence, or if at the community level there is a lack of capacity to systematically examine this intervention. This situation calls for partnerships between researchers and communities. Researchers who are interested in examining what the community is already doing rather than bringing something into the community and saying, let's try this out, and communities that are open to critically examine what they're doing. There's challenges on both sides, on the researcher side and on the community sides. The successful cumulative experience of this one individual and others like him or her that are trying something local or organic then forms the basis of what's called community-defined evidence. Martinez and colleagues describe community-defined evidence as the knowledge accumulated through the ongoing successful implementation and or evaluation of practices developed locally with significant community input. More specifically, community-defined evidence is a set of practices that communities have used and have determined to yield positive results, as determined by community consensus over time, and which may or may not have been measured empirically, but have reached a level of acceptance by the community. Interventions with community-defined evidence might be more likely to succeed when we try to scale them up because they originated from the community in the first place, rather than originating in a laboratory or in a controlled setting and then bringing it out into the community. The resulting increase in ecological validity can be an important asset in the translation from the laboratory or the controlled setting to the real world. As we continue then along this continuum of evidence, we can then begin to consider evidence that stems from more traditional empirical venues, like program evaluation, intervention research studies, expert opinion, narrative reviews, systematic reviews of multiple intervention research studies, and even surveillance data. A major strength of an evidence-based approach is the emphasis on continuous examination in pursuit of interventions that produce the best outcomes. A major weakness involves the pitfalls associated with moving from the lab to the community, moving from a pilot study to an efficacy study to an effectiveness study, or from the lab to the community. This is especially true with regard to communities of color, given their limited representation at the upper levels of the evidence-gathering continuum. So one of the major challenges that we have, particularly with minority communities, is that they are underrepresented in the higher levels. If you do take a hierarchical approach to levels of evidence, and what I'm arguing, what many are arguing, is that all of these different levels of evidence are important. But if you're just going to emphasize randomized clinical trials, then the people in these minority communities aren't participating in these studies. So you're going to try to then implement something with them that hasn't been developed with them in mind. Speaking a little bit more about this continuum of research evidence, SAMHSA and APA both have developed guidelines for what constitutes an evidence-based intervention as a manualized intervention. We're going to talk a little bit more in a moment about evidence-based both as process and as practice. But SAMHSA Strategic Prevention Framework, for example, talks about an evidence-based intervention, and in this case, SAMHSA is talking about an evidence-supported treatment or an evidence-based treatment. So intervention as a manualized intervention and not as a process is one that is included in the Federal Registry of Evidence-Based Interventions, and there's several. The CDC has one, SAMHSA has one. The one that the data, the evidence-gathering process, the research is reported in peer-reviewed journals with positive effects on the primary targeted outcome, and one where the documented effectiveness of the intervention is supported by other sources of information and the consensus judgment of informed experts, as described in 4 guidelines. You have them right there in front of you, all of which must be met. It's based on a theory of change that is documented in a clear logical conceptual model. It's similar in content and structure to interventions that appear already in registries or in the peer-reviewed literature. It's supported by documentation that it has been effectively implemented in the past and multiple times in a manner that attends to scientific standards of evidence and with results that show a consistent pattern of credible and positive effects. And that's been reviewed and deemed appropriate by a panel of informed prevention experts that includes well-qualified prevention researchers, local prevention practitioners, and key community leaders as well. So this is a tall order, and to achieve this is a long and time-consuming and expensive process. APA has similar criteria, and APA kind of divides it into three groups, and they call it well-established treatments, probably efficacious treatments, and possibly efficacious treatments. So the well-established treatments are very similar to what we were just seeing in the previous slide of the SAMHSA model. A well-established treatment has at least 2 good group design experiments conducted in at least 2 independent research settings and by independent investigation teams, demonstrating efficacy by showing the treatment to be superior to a pill or psychological placebo or to another treatment or equivalent to an already established treatment. 2, the use of treatment manuals or logical equivalent in the treatment. So there's a set of instructions that somebody who wants to replicate that intervention can follow. 3, the treatment was conducted with a population treated for specified problems for whom inclusion criteria have been delineated in a reliable, valid manner. So it wasn't just tested on anybody. It was tested on a particular a population with a particular focus in mind. 4, use of reliable and valid outcome assessment measures, at a minimum measuring the problems that are targeted for change. And 5, use of appropriate data analysis techniques. And then, so that's the highest level for APA, well-established treatments. And then probably efficacious treatments have at least 2 experiments showing that treatment is statistically significantly superior to a waitlist or no treatment control group, or 1 or more experiments that meet the well-established criteria, the one above. And those that are possibly efficacious treatments must be at least 1 study showing that the treatment is efficacious and no evidence to the contrary. So again, achieving these standards of evidence can be very difficult for interventions that are developed organically in the community, and I'll return to that in a moment. So the second piece of the definition is evidence-based as both practice and process. So as process, we're referring to evidence-based as a practice framework. And here the characteristics are clearly outlined in the NASW definition. When confronted with a problem, a client has a presenting problem, or an organization or a community has a presenting problem, what do? Well, we create an answerable question, something that can actually be answered. We find the best available evidence to answer that question. We evaluate the quality of the evidence and its applicability, and here is where the clinician's expertise comes into play, and the client's preferences and context and culture. We apply the evidence and then we evaluate. And we do this continuously, again and again and again. So this is a practice framework. This is evidence-based as a process. And then evidence-based practice as an intervention is a manualized intervention, which is what I was just talking about a moment ago in those SAMHSA and APA guidelines. And by the way, part of the challenge is that we can't seem to agree on what to call these things. So the second one, evidence-based practice as an intervention, sometimes we see it in the literature as evidence-based interventions, sometimes we see it as treatment-supported interventions, sometimes we see it as empirically supported interventions, sometimes we see manualized interventions. So there's all of this language that is used that sometimes confuses the issue rather than developing clarity. And then the third piece of the definition is the role of culture and context. All 3 definitions of evidence-based practice, the Institute of Medicine, APA, and NASW, emphasize practical fit with the community's needs and resources and the appropriateness of the interventions to the population and the community, the context and culture and local circumstances. We know from a lot of research that cultural competency can play an important role in eliminating disparities in services and programs offered to people of diverse racial, ethnic, and linguistic backgrounds, gender and sexual orientations, and those with disabilities. So culture and context and life experience and circumstance matter. It matters in many different ways, whether I accept the intervention or not and how I'm going to respond to it. Unfortunately, minorities of all of these groups that we just saw are underrepresented in research that produces the evidence, and especially in that higher level of evidence that some want to see, which is the experiment or randomized clinical trials. This shouldn't surprise us that minorities are underrepresented because minorities mistrust the research enterprise due to a historical legacy of mistreatment and unethical behaviors. And this mistrust tends to be mutual. For example, an analysis conducted for the Surgeon General Report on Mental Health, Culture, Race, and Ethnicity found that of over 9,000 participants that had been involved in efficacy studies or randomized clinical trials that shaped the major evidence-based treatment guidelines for bipolar disorder, schizophrenia, depression, and ADHD, only 6% of these participants were African American, 1% were Hispanic, 0.1% were Asian, American, or Pacific Islanders, and none of them were American Indians or Alaska Natives. So this creates a very serious problem when I take an intervention that was not developed for a community, for a population, and then I want to come in and I want to apply that intervention to that community. There's lots of things that have not been taken into consideration. This underrepresentation in randomized clinical trials in particular continues despite a mandate by the National Institutes of Health to include and increase the representation of women and minorities in clinical trials. So we're doing better, but we still have a lot of catching up to do. Where are we with evidence-based for Hispanics? Why are they important for Hispanics? Well, we all know Hispanics is the largest minority group in the country. We're now at about 17% of the population, and we're still growing very, very rapidly. Hispanics are confronted with multiple stressors that put them at risk for a host of health conditions, medical disorders, substance use disorders, psychiatric disorders. Hispanics are also impacted by multiple health disparities, and yet most interventions are not developed with or for Hispanics. So again, we take an intervention that wasn't developed for a group and we try to apply it to that group, and a lot of things can go wrong. Sometimes things go right as well. Hispanics are especially underrepresented in research protocols that are used to generate evidence for mental health interventions. And as we move up this hierarchy of evidence, all the way up to these randomized clinical trials, the number of Hispanics in those studies gets smaller and smaller and smaller. And evidence-based mental health treatments may require culturally informed modifications to best address the unique needs of the Hispanic population, but few existing empirical studies have assessed these cultural elements. So there's a lot of literature on adaptation, and sometimes we talk about adapting the intervention, and sometimes we talk about adapting the interventioner, but it's a very complex and elaborate process, and we have some guidelines on how to do it, but it's challenging to do. It takes time and resources and know-how. So let's look a little bit at evidence-based for Hispanics in substance abuse. Well, the shortage is there as well, just as in mental health. Severe shortage of treatment for substance use disorders that have been adequately tested with Hispanics. In preparation for this presentation, I went to SAMHSA's National Registry of Evidence-Based Programs and Interventions. It has over 340 of them, and I did an advanced search using, it allows you to select certain things. So I selected interventions for substance abuse treatment for Hispanic or Latino as the population, and it gives you the option to limit the search to interventions that are evaluated in studies that have a higher percentage, defined as 50% or more of the selected group. And I got 6 out of 340 plus interventions. Brief strategic family therapy, functional family therapy for adolescent alcohol and drug abuse, Interim Methadone Maintenance, Psychomedical Intervention Model, Phoenix House Academy, and TCU Mapping Enhanced Counseling. 6 of them. Of course, if you alter the parameters of the search, you'll probably get a higher number of them. And you know, I don't want to give the impression that the thing is to go to the other extreme, that every intervention has to be tailored for every single aspect of a client, but we know that culture and context matter. So at least those things need to be taken into consideration. So given this state of affairs, where do we go next? And what I lay out in the white paper, and I'm replicating here, is a set of recommendations to try to address some of these challenges. So we need to expand funding to examine those interventions that have emerging evidence, those interventions that maybe are organic. They started in the community. There may not be local capacity to evaluate or local funding to evaluate. We need to expand funding to that. And all too often this is challenging because all too often you look at a request for proposals and they're requiring that you use an intervention that has a higher level of evidence already. The second recommendation is to designate funds for researchers that are working on community-based interventions that are targeting particularly Hispanic subpopulations. So this involves the federal government making funds available directly to community-based researchers via discretionary funds rather than only through block grants to the states. Because a lot of this can be funded by the states, but it's not in the priority of the states. Third, encourage collaborations between researchers and service providers. I was alluding to this earlier. You know, there is a natural mistrust of the research establishment in communities, and for good reasons. You know, the historical legacy of unethical research, but also the drive by research that researchers from academic institutions often involve in. They go into a community, you know, they engage a community in research, and the moment the funding dries up, they're gone, and sometimes even before then, you know, once they've collected their data. So that mistrust is understandable. The providers can actually bridge the gap between the community and the researchers. So stronger collaborations between the researchers and the service providers and the community are necessary. 4, broaden and deepen our understanding of the culture and community context of Hispanics. You know, a lot has been written about our Hispanic communities, and sometimes I'm amazed about how little we actually know about what goes on in some of these communities. We have to do much more work to truly understand how our community views the issues that they deal with, what they see as possible solutions. What they bring to the table, the strengths of the community. And then lastly, to encourage adaptation and cultural modification of those evidence-based interventions that already exist. And that there's some work being done in that in many different areas. There are interventions that are adapted particularly for Hispanics, but also for other communities. But in addition to that, that adaptation process is important, but in addition to that, we also have to encourage and support and fund the development of organic interventions, those that come up from the ground, from the community, those that are developed by Hispanic communities, with Hispanic communities, and for Hispanic communities. So I'm going to stop there and return the presentation back to Daris, so we can open it up for questions and discussion.
Thank you, Luis. Thank you very much. Okay, so we have a couple of questions, and one of our participants was wondering if some of these models, if you have any knowledge, if they are applicable to veterans and their families.
The evidence-based intervention or models applicable to veterans and their families. It's not a population that I necessarily work with, but if you go to that National Registry of Evidence-Based, and if you just Google SAMHSA's National Registry of Evidence-Based Programs and Practices, veterans is one of the populations that you can search for. So it is possible to find I would be surprised to learn that that was not the case.
Okay.
Because it is a high. Let me look at it for here right for a second. I'm actually on that web page right now.
Okay.
I don't see. Let me uncheck the categories that I had checked. I just typed into the search veterans. And you know, I just typed in, just in a general search, the keyword veterans, and 19 different interventions came up.
Okay.
So those are interventions that, you know, either have been tried with veterans or tested with veterans, or veterans are part of the samples that were used to generate the evidence. So it's a very useful tool. So I recommend that people go to it, bookmark it, become familiar with it. It's SAMHSA's National Registry of Evidence-Based Programs and Practices.
Mm-hmm. Thank you. Just a question about SPIRT. Do you have any knowledge of the screening, brief intervention, and referral to treatment applied in Hispanic populations? If so, what cultural changes might be needed to make it more effective with Hispanic communities?
Well, we're actually using SPIRT as part of our SAMHSA Smart Cougars project. You know, and for those in the webinar who may not familiar with SPIRT, screening, brief intervention, and referral to treatment, it's an approach that incorporates motivational interviewing, identifying risk factors that the person might have, and tailoring developing a tailored risk reduction plan for the client that you're working with. Now, because of the nature of SPIRT, that one of the things that you want to do with SPIRT is actually tailor the plan to the context and the circumstances of the client that you're working with. You know, race and ethnicity is part of that. So SPIRT is actually one intervention, one approach that lends itself beautifully to be used with many different types of clients, because it doesn't use a cookie-cutter approach. Mm-hmm. So we're using it, for example, here in our Smart Cougars the project. You know, we're using it with Hispanics and African Americans in particular. But you know, some of the Hispanics are international students from Mexico or Latin America. Some of the Hispanics are first-generation immigrants. Some of the Hispanics that we have in the university are second, third, fourth, fifth generation. Some of the Hispanics are those that say, hey, the border didn't cross, we didn't cross the border crossed us. Mm-hmm. So they have different socioeconomic backgrounds. You know, they come from different nationalities, right? So, but all of that is taken into consideration in as much as when you're doing SPIRT, you are tailoring what you are doing to the specific circumstances of the client.
Okay, perfect. Okay, we have another one. Is there evidence-based research designed for Latinos who are migrants with or without documents?
That's a great question, and I get that question a lot. I'm just out of curiosity. I'm typing into the registry search, mm-hmm. undocumented, just out of curiosity, and nothing comes up. You know, my answer to that question would be, I would be floored if it doesn't exist. The problem is identifying as such, because you know, I can tell you, for example, that the research that we do here, you know, in the center, and other colleagues that I collaborate with closely, documentation status is not something that we ask about for many reasons. You know, there are ethical issues. The IRB 99% of the time won't even allow you to ask about documentation status. So, you know, the Hispanics that are participating in research studies throughout the country aimed at generating evidence for a particular intervention, I can guarantee you that some of them are going to be undocumented immigrants. But since we know that Hispanics overall are underrepresented in research, as participants, we also know that these undocumented immigrants, well, immigrants in general, not all Hispanics are immigrants, but since Hispanics are underrepresented, immigrants are going to be underrepresented, and then undocumented immigrants are going to be underrepresented as well. And that, that makes sense when you think about it. Where is it that most of these research studies take places? Well, they're done typically by university centers, so undocumented immigrants aren't going to come to the university. They might be fearful of coming in. Students are a different story. We have the DACA students and Dreamers, and they're here, they're with us, and they're open about their situation, and they participate in things. But undocumented immigrants more broadly, if it so happens that a research study is taking place in the community with an organization that serves that population, then they might be able to participate. In the national implementation evaluation of the Hispanic Healthy Marriage Initiative that I was a part of, that was a 6-year project actually, many of the programs that we visited were serving undocumented immigrant communities, undocumented immigrant Hispanic communities, and the participants, we did focus groups in addition to interviews, in-depth interviews with the staff, and the participants talked about that openly in the focus groups, those that were undocumented, probably because the people that were leading the focus groups, in many cases were Hispanic. The focus groups were in Spanish. These focus groups were taking place at the organization itself, at the agency. So there's an element of kind of an automatic trust that's given. So they talked about it openly. But the programs didn't collect that data. It wasn't part of the criteria for received services or not. So anyway, that's a long-winded answer just to say that, in as much as Hispanics participate in research that's undertaken to generate evidence, yes, I'm certain that immigrant Hispanics and undocumented immigrant Hispanics are also represented, but probably in low numbers.
Okay. We have a few other questions. We'll see if we have enough time for all of them, but I want the audience to know that if we don't, I will send you the questions, Dr. Torres, and we can post the answers on our website so that everyone has access to them. Okay?
And I can have a little bit more time to research some of the things that have been asked and give some more concrete answers. Like the question of, of veterans. Now I want to know the answer to that. So, I can do a little bit more research. And the second question also, I'd like to, if there are studies that are going on specifically for that population, for undocumented immigrant Hispanics, it'd be interesting to know about them and also to know who's funding them.
Okay, so perfect. We have another one. What EBPs do you think are the best to use for substance use in women and children? Do you have any recommendations? This is from someone who works at an outpatient setting.
Well, for Hispanic children, it's definitely brief strategic family therapy, which was developed by Dr. Shaposnik's team in Miami, is one that quickly comes to mind. Of course, you have to be trained in it, and they do offer training, and it's very complex, and it takes into consideration, the family. That one of the core cultural values for Latinos is the primacy of the family, and the SFT actually takes that into account, and changing dynamics in the family, power dynamics, all those sorts of things. For women, it's a little bit more complicated because it depends on what the presenting problem is. In addition to substance abuse, many women often may have histories of trauma, for example. Sexual trauma is very, very common. The other thing we haven't talked about, in my slides, I talked separately about interventions for mental health and interventions for substance use, but we also know that there's tremendous overlap between the two. So if you're talking about evidence-based interventions for co-occurring mental health and drug use disorders, then the thing gets even more complicated. So now then you add the element of gender. So, an evidence-based intervention for a woman who is suffering with both a psychiatric disorder and a substance use disorder, and may have had, a history of sexual trauma. And, we just want to complicate it even more. You keep complicating it. We're just talking about undocumented immigrants, Maybe that it's an undocumented immigrant, or that it's a veteran, the first question that asks. It gets really complicated how much you want to slice it. And then, what I was alluding to earlier is I didn't want to give the impression that we need to get to the extreme and slice it so thin that we have one intervention per person. And that's really not what we're talking about. At the end of the day, there are other things that are also, important. A provider that is well trained, that is compassionate, that understands the pain and suffering that the client is going through, that is skillful in eliciting information from the client and engendering trust so that the client can be, open to engaging in whatever the treatment is at the end of the day. And then if you mix those things with a treatment that is well supported by the evidence, then you may have a higher likelihood of success. For example, I don't know if Seeking Safety has been actually tested with Hispanic women.
Yes,
but,
it has included women in its samples, yes.
So
and actually we are using Seeking Safety here for a project in Puerto Rico. We have an ongoing project, and the model that was selected was Seeking Safety.
There you have it.
Mm-hmm.
I know Hortensia Amaro, when she was in Boston, was using it with a lot of the women that she worked with. She worked with multiple centers. She's now in California. So they're Seeking Safety is an evidence-based model that's been shown very successul with women with substance use histories and trauma histories, and it's included women. So
yeah,
but, as providers, we need to get into the habit of doing our homework. When I was in training many years ago, my training was multidisciplinary, so I was also with a lot of medical students. And one of the things that I admired the most about these medical students, who they were ravenous readers of the literature. They were assigned a particular patient with a particular diagnosis, and they'd go to the library. They would hit those books and those journals, and by the next day, they knew everything that had ever been written about, that particular diagnosis, right? And a lot of times we don't do that in the delivery of psychosocial intervention, and we got to get into the habit of doing that, continuously training ourselves, going to conferences, going to workshops, reading up. When you belong to a professional organization, typically many of them have a journal that you can receive and read that kind of research that's being published in that field. So we got to continuously update our knowledge of the populations and the conditions that we work with.
Mm-hmm. Okay, so one more question, one comment, and then, as I said, we can post the answers on our website. People have been asking for the specific link for the registry, so we'll provide that as well. And the next question is how might you address within group differences across diverse Hispanic populations?
That's a great question. I mean, that that came up. Actually, that's come up in many of the research that I've been involved with. Going back to the, to give you a very specific example, the National Hispanic Healthy Marriage Initiative evaluation. There were one of the sites that we visited served both a immigrant, more recent arrival Hispanic group and kind of a second generation, much more acculturated group, and they had them sometimes together in the same group. They had different groups in English and in Spanish to give clients a preference of which ones they would, but there were some of the second generation Hispanics that were primarily English speakers, but they wanted to participate in the group in Spanish. They wanted to connect more to that. And so they had some groups that were mixed, that had recent arrivals, spoke very little to no English, and then they had second-generation Hispanics that were primarily English speakers but had some knowledge of Spanish, and then they were more acculturated as well. So, for example, they talked about when they were addressing issues of sexuality, talk about within group differences. When they talk about issues of sexuality, they found that the second-generation women, in particular, were very open about it and very gung-ho, and they could talk about it openly in the group, and the men as well. And then the more recent immigrants were very quiet and withdrawn and shy, and they felt that it wasn't appropriate to talk about those topics in such a large issue. So one of the things that they did in that context was, separate them into smaller groups. So address that particular issue in a smaller group setting, grouping them by characteristics like the ones that I just described. Those that were primarily Spanish-speaking and more recent immigrants, less acculturated, perhaps higher in religiosity, and finding it challenging to speak about this openly, and then the other group who was more acculturated, primarily English-speaking, a little bit more secular in their views and more comfortable with topics of sexuality, and rather than addressing it all together. So that's just one very simple example on how you can think about some of these things. And the data comes from the participants. It is your participants. If you're talking about within group differences, I'm assuming that you're talking about delivering services in a group setting. You have to listen to what your participants are telling you. And I don't just mean what they're telling you verbally, but how comfortable do they seem with pieces of the intervention. And remember that evidence-based as process calls for continuously assessing how it's going. What's is it working? Is it not working? And I don't just mean in terms of what's the outcome measure showing, but something like attendance, engagement. If you're going through and people start to miss sessions, something's happening. It might have nothing to do with what's going on in the treatment, but it might have everything to do with what's going on in the treatment. So you have to assess that. You have to ask questions about that. You have to check in with your clients regularly. How is it going? Is this working for you? What's getting through? What's not getting through? And then you have to listen to what they're saying.
Okay. Thank you so much. Okay, so we have a few more questions, but we're not going to have enough time for that. So as I mentioned to the audience, what we'll do is that we'll post questions and answers on our website along with the PowerPoint slides and a recording of today's webinar. Okay, so again, I want to thank Dr. Luis Torres for collaborating with us in this effort today. It was really interesting, and really we understand that there's a lot more work to do, so hopefully we'll move in that direction. So remember that there will be a copy of today's webinar and the PowerPoint slides, and they will be posted at our website at appc.org/Hispanic Latino. So this concludes today's webinar, and I would like again to thank Dr. Torres, and I'd like to remind you that we have other webinars coming up. So as you leave today's webinar, you'll be directed to complete a brief survey about your experience. Your feedback is very important to us, and we appreciate you taking the time to tell us what you thought of today's webinar. So thank you, everybody, and have a great day.